Hi all, it is very glad to meet you all in this video lecturing. Myself, Professor S.Semmalar, Department of Medical and Surgical Nursing, Physiology College of Nursing, going to deal with this topic. So my course name is Medical and Surgical Nursing. My topic is myocardial infarction. So today we begin this myocardial infarction by giving the brief introduction. Introduction about myocardial infarction. As we all know, myocardial infarction is a serious injury and also it is a medical emergency, not only in India, globally. And also it needs the emergency care to safeguard the patient suffering from myocardial infarction. So myocardial infarction, commonly known as a heart attack, occurs when blood flow decreases or stops to a part of the heart, causing damage to the heart muscle. The most common symptom is chest pain or discomfort, which may travel into the shoulder, arm, back, neck, or jaw. The other name of myocardial infarction, we can say it is myocardial infarction or MI, or we can say it is a heart attack, or we can say it is a ischemic heart disease. Whether MI, heart attack, or ischemic heart disease are all similar to the myocardial infarction. So nothing, myocardial infarction is a medical term, whereas the others will be used by all the people. The global epidemiology about myocardial infarction, it is evident that myocardial infarction is the leading cause of morbidity and mortality worldwide. It is responsible for over 15% of mortality each year among the vast majority of people suffering from non-ST elevated MI than the ST elevated MI. The prevalence of MI is higher among men in all age specific groups than women. So this is nothing. The prevalence goes to the MI or the risk factor goes to MI gender wise till menopause. Men and women are equally sharing the risk factor. But whereas after menopause, the women are more higher risk than female. It is believed that because of the role of the estrogen in preventing the atherosclerosis plague. The global epidemiology continues as the CVDs, that means cardiovascular disorders, are the #1 cause of death globally. More people die annually from CVDs than from any other causes. An estimated 17.9 million people died from CVD in 2016, representing 31% of all global death. Of these deaths, 80% are to the heart attack and stroke. Over 3/4 of CVD death take place in low and middle income countries. And this figure I want to incorporate. So here in India, it will be higher than globally, since the reaching time to the casualty will be delayed when comparing to the other countries. So out of 17 million premature death under the age of 70 due to non-communicable diseases in 2015, and 82% are low and middle income countries, and 37 are caused by cardiovascular disorders. The last will be the most cardiovascular diseases can be prevented by addressing behavioral risk factors such as tobacco use, unhealthy diet and obesity, physical inactivity, and the harmful use of alcohol. So here, pertaining to Indian lifestyle, so here there are many use of tobacco, smoking, alcohol, and unhealthy diet habits will be common for all the whether low or middle or higher income status. And obesity also is very higher comparing to the other nations. And here the abdominal girth will be more than 100 centimeter, also will contribute to the risk of developing cardiovascular diseases as well as the diabetes. The universal definition of myocardial infarction are, it refers the tissue death of the heart muscle or myocardium caused by ischemia. that lack of oxygen delivery to myocardial tissue. It is a type of acute coronary syndrome which describes a sudden short-term change in symptoms related to blood flow to the heart. So before going into the disease condition in detail, so let us refresh our mind by reviewing the anatomy and physiology of the heart. So we all know about the heart a little bit. So here, just refreshing for your mind. So we all know the heart is situated around, it is covered by 3 layers. So here is the endocardium, and middle layer is the myocardium, and outer layer is the epicardium. So in these 3 layers, only the myocardium is the thickest layer. So why it is thickest means it is since contributing to the myocardial contraction. So by nature itself, it will be very thicker than other 2 layers. And then there are 4 chambers is there. So right atrium, right ventricle, and left ventricle. And then we have right side tricuspid valve and left side bicuspid valve. So tricuspid valve, it is a lumen allowing the blood from right atrium to the right ventricle, whereas bicuspid valve allows the blood from left atrium to the left ventricle. The name has arisen because of the 3 lumens means it is a tricuspid valve, and the 2 lumen means it is called the bicuspid valve. And also we have semilunar valve as well as the mitral valve as well as the pulmonic valve. So here it comes to the valve. So these valves are allowing the blood from systemic circulation as well as to the pulmonary circulation. So here we have superior vena cava and inferior vena cava. So let us come to this is about the structure, and this is the aorta, and then here is the pulmonary artery. Again, the pulmonary artery is taking 2 divisions, right pulmonary artery and left pulmonary artery. So right pulmonary artery goes to the right side of the lungs, and left pulmonary artery goes left side of the lungs for the purification. So coming to this picture, this is about the circulation. So we have 3 circulation. One is the pulmonary circulation, and another one is the systemic circulation, and last one it is the coronary circulation. So here in the pulmonary circulation, there will be a deoxygenated blood supply, and the systemic circulation carries the oxygenated blood supply. Whereas coronary circulation, here it starts before the aortic valve, and it is entirely for the supply of blood to the heart. So let us begin with the superior vena cava. So superior vena cava collects the blood from upper parts of the body and leaves the deoxygenated blood in right atrium. Whereas in the inferior vena cava collects the deoxygenated blood from the lower part of the body, and also it is an extension of hepatic vein. And also it leaves the blood in the right atrium. So through tricuspid wall, blood enters into the right ventricle. And then from pulmonic valve, blood enters into the pulmonary artery. Here it takes 2 divisions, right pulmonary artery and left pulmonary artery. There, after it reaches the lungs for the purification in the alveolus, then oxygenated blood enters into the pulmonary vein into the left atrium. From left atrium, blood enters into the mitral valve, and then it goes to the left ventricle. So from the left ventricle, blood enters into the aorta. So here, before entering into the aorta, the coronary artery takes division. Again, the coronary artery divides into 2, right coronary artery and left coronary artery. This is purely supply for the heart. And then this aorta takes 2 divisions. One is arch of aorta, ascending aorta, and descending aorta. So arch of aorta is for head and neck, and ascending aorta for upper part of the body, and descending aorta for lower part of the body. It supplies the blood. So this is about the small review of anatomy and physiology of the heart. So next it is the coronary artery disease. So here we are going to begin the myocardial infarction. So the myocardial infarction, actually it develops as stages. So we say in common coronary artery diseases. Here there are 3 stages are there. One is atherosclerosis, and second stage is angina pectoris, and third stage is myocardial infarction. So atherosclerosis is a plaque formation and angina pectoris. Because of this plaque formation, the patient will get chest pain. But the thing is, which is relieved by rest or NTG. So even this stage also the patient is ignored and not going to hospital means it may develop as a myocardial infarction. So let us discuss this in detail by using the diagram. So this is the atherosclerosis, how the plaque is formed. And here, pertaining to atherosclerosis, it is not developed in a year or in the months. It will take some more than 5 years or more than 10 years to develop the atherosclerosis. So first we all know the risk factors, what the Indians and globally the human beings are adopting. Gradually the fat deposition occur in the intimal layer of the arteries, coronary, especially in the coronary artery. So here this atheroma will be formed. This is a stages. It will take 10 years, there will be a small growth. And after 20 years, see the deposition will be higher. And 30 years will be more higher, and 40 years it will thick. It will be more thick. So when it is gradually it is developing, this we can say atheroma, fibrous plaque, as well as the complicated lesion. So the atheroma and fibrous plaque will allow the blood to the heart, whereas when it is coming to the complicated lesion, the thing is it may rupture sometime, and there the patient might end up with the myocardial infarction. So here in atherosclerosis, this development, next stage will be the angina. If we talk about angina, that will be a bigger, just a small view about angina is we have unstable angina, stable angina, Prince-Metters angina, nocturnal angina. So these are all the divisions which is based on the character of the angina. But here it is not our topic about dealing with the angina, but still it is a second stage. So here we are relating some of the points regarding the angina pectoris. And during this stage only, patient will have pain. But the hallmark difference between the angina pectoris and the myocardial infarction is the pain only. But in angina pectoris, the pain will be subsided or it will be relieved after taking rest or NTG. Whereas the third stage is the myocardial infarction. So here see the plaque will be more and the occlusions also will be more. So this causes the obstruction of the blood flow to the myocardium. So in this stage only, the patient will end up with the severe chest pain, or we can say it is a myocardial infarction. So here to mention about the pain, in angina pectoris, the pain will be relieved after taking rest or NTG. But whereas in myocardial infarction, the pain will not be subsided after taking rest or NTG. So this is the hallmark difference between these two. A person or the patient, if identifies, we can save the patient by giving immediate treatment to the myocardial infarction. Next, about the types of myocardial infarction. Here, when you are talking about the types of MI, it is based on many things. So first we will discuss about them. It is based on ECG. So here there are two types is there. One is STEMI and another one is the non-STEMI. STEMI means here is the ST elevation. Here is a S wave and here is a T wave. And after this one, we have to begin with PQRS complex, but here the curve is extended. So we say here it is a ST elevated MI. And whereas this is also one type of MI based on the ECG. So next is this is the MI only, but the ST elevation will not be there. Instead, there will be a ST depression will be there. Instead of the waves is elevated on upside, here it will be depression will be there. So this makes when you see the ECG, by this we can find out whether the patient is having ST elevated MI or non-ST elevated MI. Next, it is the classification. The classification is based on location. Location in the sense, in the heart. This is the anatomy of the heart. So where the MI is occurred, based on that we can do the classification. There are 5 classification is there. Here we can say anterior wall MI. So this is the anterior wall MI. And why only that picture is displayed means the most of the patient, almost more than 70% of the patient may undergo for anterior wall MI. So based on the anatomical location. Here, if it is there, here, if it is there, this is the inferior wall MI. And then here, the MI is occurring. This is called posterior wall MI and lateral wall MI. Posterior and the lateral wall MI is very rare only. And this is the acute right ventricular MI. So this is the classification of MI based on the location. So next it is the etiology. So coming to etiology, there are so much etiology is there. But at this level, I feel this is enough. So first it is a tobacco smoking. And this is the major reason or risk factor we can take it into the consideration. So next it is the hypertension and then drug abuse, obesity. Obesity in the sense there will be abdominal girth will be more and it is heart cannot able to pump that much amount of blood. So over workload, once it leads to the myocardial infarction. Next, it is the stress and then taking the alcohol. So these are all some of the risk factors. So coming to the risk factors, we have 2 types of risk factors. One is modified risk factor and another one is non-modified risk factor. So the name itself we can identify. Modified means you can do the modification, whereas non-modified means you can't do any changes. So here, as we saw in previous slide, tobacco use, sedentary lifestyle, so not doing the exercises, and the diabetes, this and all comorbidity and endocrine disorders, hypertension, hyperlipidemia, smoking and alcoholism. So these are all some of the risk factors may develop into the myocardial infarction. So next it is the important one, which you can't do anything, that is the non-modified risk factor. First one is the age. So coming to the age, when the age increases, and there will be a risk also increases, that is positive correlation. Next it is a gender. So when you take gender, male and female are having equal risk factors till the menopause. But after the menopause, the women are more high than the men. And the race, coming to the race, the African Americans are having more risk to develop the myocardial infarction. And the hereditary is, if the father or mother is having the myocardial infarction, and the next generation will be getting the 50% of chance to develop the myocardial infarction. If one father alone is having myocardial infarction, means the next generation will have 50% of chance, whereas mother also is having, means that other generation will have 100% of chances. But whereas you can prevent by using the preventive measures in appropriate age. So next, coming to the pathophysiology. So here in pathophysiological changes, there are, for the simple form we have explained here, there are 3 factors involved in the changes. So first it is the atherosclerosis, that is obstruction, and the arterial spasm. So the spasm, the obstruction will be more in percentage and it leads to the spasm. And this arterial spasm leads to sudden irreversible obstruction. And then atherosclerosis plus plaque as well as a thrombus. So these 3 leads to the occlusion. So now atherosclerosis and then plaque split as well as a thrombolysis, and occlusion leads to ischemia. So here, this ischemia is the lack of blood supply here. So if it is lack of blood supply is there to the myocardium, definitely oxygen supply will be less. That is, we say in medical, hypoxia. So this hypoxia means reduced level of oxygen in the blood. This leads to reduced oxygen demand. So in this stage, the patient will have chest pain, that is angina. And then here, if the patient is very alert and it is not ignorable, means we can treat them. And if it is patient is ignorable, means then they may think it is the pain is due to some other reasons, means then this will be prolonged, then it leads to thrombolysis, that is called the unstable angina, and then permanent thrombus formation will be there, and this leads to the necrosis. That necrosis will be your myocardial infarction. Next, it is the signs and symptoms of myocardial infarction. First, I said before itself, pain is the hallmark sign of the myocardial infarction. Whether to differentiate between angina pectoris or MI alone, so the pain will give you more information than reaching into the hospital. So let us discuss in detail about how the pain will be. Actually, the pain will be radiates most often to the left arm. Okay, this left arm, and it is also radiate to the jaw, neck, right arm, and back side, as well as the upper abdomen. So in this stage only, patient will interpret with the gastric trouble. So because of that the pain is occurring, they will take some home remedy, and then because of this delayed arrival to the casualty, we are losing many of the persons. So this is about the characters of the pain in the myocardial infarction. So other than that, there are so many associated symptoms is there, but here I have given only important things. So first, it is a chest pain may be accompanied by sweating, nausea, vomiting, and fainting. And these symptoms may also occur without any pain at all. Here in this sweating is profuse sweating will be there. Suppose when you touch the patient, they feel very cool and calming. In women, the most common symptom of myocardial infarction include shortness of breath, weakness, and fatigue. Shortness of breath is a common and sometimes the only symptom occurring when damage to the heart limits the output of the left ventricle, with breathlessness arising either from low oxygen in the blood or pulmonary edema. The other less common symptoms include weakness, lightheadedness, palpitations, and abnormalities in heart rate or blood pressure. So other than these associated symptoms, system-wise, we have some of the symptoms, but that will be in very detail, but here this is enough, I feel. And then here, about the diagnostic evaluation. So here is the first one is the electrocardiogram, and second will be the blood test. The blood test is the most important is cardiac enzyme. So let us this cardiac enzymes in detail in forthcoming slides. The echocardiogram, and the echocardiogram will give you the ejection fraction and chambers and circulation. Nuclear scan, chest radiographs, coronary angiograph, exercise stress test, cardiac CT, and then MRI. So here we'll see one by one. First, it is the ECG. So ECG only will give the more information whether the patient, as we saw before, whether it is a T wave inversion is there, ST depression is there, or ST elevation is there. So by seeing the ECG, we can find out patient will be having ST elevated MI or non-ST elevated MI. Next, it is the cardiac makers. The cardiac makers is nothing, the myocardium, so which is necrosed and the myocardial damage is there. So for temporarily, the myocardial death will be occurred. So these myocardial death cells, after the death, it will be releases some of the makers or some of the enzymes. We say it is a cardiac makers. And these enzyme is called cardiac makers or cardiac enzyme. So this is actually we have troponin, CKMB, and myoglobin. So in the troponin we have I and T, troponin T and troponin I, and creatinine kinase MB, and then myoglobin. So these are all the three cardiac enzymes will give you the clear information whether the patient when the MI is occurred and how severity it is. So that is about the cardiac makers. Next, about the cardiac risk evaluation test. So first it is a total cholesterol. We all know about the high density cholesterol, very low density and low density cholesterol, and TG cholesterol. This is important thing while checking the for myocardial infarction. Not only myocardial, this as well as for atherosclerosis and then angina pectoris. So next test is the cardiac injury panel test. Here CKMB, SGOT, LDH, SHBD, troponin, and myoglobin. So these are all the, this is based on the hospital policy, whether they go for group 3 test or it is enough with the group 2 test. Next, it is the medical management. So here, under the medical management, so this medical management itself will be the vast one, because the medical management will be divided into even 5 category or 3 category. First, when the patient receives from the casualty, so there what are all the treatment to be given, and then from the casualty, patient will be shifted to the ICU. So there what are all the care will be given for first 12 hours and then 24 hours, and then later what is the treatment will be carried out. Here I have organized everything to give a gist manner. And then first it is a immediate management for the first 12 hours. So here we can give analgesic morphine sulfate, and the patient tells they have vomiting is there, we can give antiemetic, and then antithrombotic therapy, and then that is we say 2 categories. One is the antiplatelet therapy and anticoagulations, and next it is the anti-anginal therapy, and next it is the surgical management. So let us discuss one by one what it is. First, it is a immediate and general management. We can say by for our remembrance purpose also MONA. MONA is nothing like we should give oxygen at 4 liters per minute in the casualty, and then we should give aspirin 160 to 325 mg, and then nitroglycerin it will be given in sublingual or spray. So whatever the forms is available in the casualty or the hospital policy, that will be given. Only the drug nitroglycerin, we say it is NTG, will be available in all the forms. For example, it is available in the spray, it is available in the injection, or it will be available in the cream, and it will be available in the patches, and then it is like the paste also it is available. So this is the emergency drug will be given immediately to the patient, and that is the NTG. So which will give the vasodilatation temporarily to the patient. Even the patient at home, if patient feels chest pain, and until he or she has to reach the casualty means, if they have NTG, they can keep under the tongue. So it will save the life, and also it gives the vasodilatation, and it will dilate the coronary artery so that the blood supply will be more to the myocardium, so that we can save the life of the person. And next it is the morphine. So morphine is a narcotic drugs, and you all know it will be given with the prescription only. So this is the, for remembrance, we can have MONA, that is morphine, and then oxygen, and then nitroglycerin and aspirin. These 4 will be done in the casualty to save the life of a person. The next it is the MI management in first 24 hours. So this is very crucial period of the patient to save the life of the person. So first it is a limited activity for 12 hours. And monitor more than 24 hours. No prophylactic antiarrhythmic drugs will be given. Here, IV heparin, if the patient is a large anterior MI or PTCA, percutaneous coronary angiogram, and then LV thrombus or altiplase or retiplase use for 48 hours. And then subcutaneous heparin for all other MI. And then aspirin is indefinitely. And IV NTG, that is nitroglycerin, for 24 to 48 hours. If no increase or decrease heart rate or decrease BP. So here, so before giving the NTG, the nurse must identify these criteria. Suppose a patient is having increased level or decreased level of heart rate or decreased BP is there, he or she should consult with the cardiologist before administration of this emergency drug. And next it is the IV beta blocker. If it is, this is given if no contraindications. And then ACE inhibitor in all MI if no hypotension. So that is, if it is no hypotension, then ACE inhibitor will be given. So next it is the surgical intervention. So under the surgical management, so we have some 4 management system we are having. And first it is the angioplasty, and next it is the stent placement, and next it is the coronary artery bypass grafting, and last one it is the PTCM. Here, coming to the angioplasty, whether we go for angioplasty or stent or coronary artery bypass graft or PTCA, this all depends upon the percentage of the block in the coronary artery. For example, suppose we are adapting and we are emphasizing for CABG. They should have some criteria to go for the CABG. First, it is a construction of new conduits between aorta or other major arteries with the help of CPP machine. And then indication is the patient will have, suppose, triple vessel diseases. 3 vessels are having block, and that block will be more than 60% of occlusion. And then with this one, suppose we given a medical management. Suppose the medical management is fails. Other than that, the patient is having 60% occlusion and it is a triple vessel disease, then we go for a coronary artery bypass grafting. And a little more detail about the coronary artery bypass grafting here. So here is the block. So suppose if you see the diagram here, the block will be, I think, more than 80%. So small amount of blood only goes to the myocardium. So almost block will be very high. So here what happened? So this stent or PTCA will not work out. So for this reason, we go for coronary artery bypass grafting. So the saphenous vein from the leg is removed and is anastomosed proximally to the ascending aorta. Here is the ascending aorta. And then distally to the coronary artery, and this bypass, the blood circulation from the coronary artery to the ascending aorta will be made by surgical intervention. So this is called the coronary artery bypass grafting. While taking this portion of saphenous vein from the leg, if it is a female, means they will take from the mammary arteries also, because since it is a bigger and thicker one, it will be used, and this is according to the choice of the cardiac surgeon. So this is about the small interpretation about the coronary artery bypass. So this picture shows before the surgery how the block, so that is this one, and this shows after the surgery how the bypass is made and creating the artificial blood circulation between the coronary artery and ascending aorta. Next surgical management is the PTCA. This we have been using from longer period, percutaneous transluminal coronary angioplasty. So if it is an angiogram, it is a diagnostic purpose. Since it is angioplasty, it is a repair. So here will be the plaque. The plaque formation will be there. Stent will be placed, and here will be the balloon. So now the insertion of stent or plaque will be here inserted first, and balloon will be there. So here the B picture is how it is inflated, how it is extended. and the balloon is inflated from outside, means how it will be extended. So here the blood circulation will be less. So this is only what the patient is having, the arterial occlusion. This red color will be the your arterial occlusion, and stent will be placed. So now when the inflate the balloon, how the structure will be. And after inflating, the balloon will be removed. That is a C picture. So only stent will be there. So this stent will be keep in a position for the arteries so that the blood supply will be goes without any obstruction. So this diagram explains in, I hope, very clearly about the PTCA. Here is a narrowed artery, here balloon inflated, and after the inflation, the stent will be placed in the intima layer of the coronary artery, and then balloon will be taken out. Now the stent will be in a place. This is about the PTCA. Next, it is the stent placement. So here, deflated balloon and then inflated balloon, and it is the open shunt. So this is the more picture view for that it is displaced here. And next, it is the complications of myocardial infarction. So one of the major disease is the myocardial infarction, and it will be treated, and it will be lifelong. They should take some of the drugs also, and also it causes some of the complications. So let us see what is the complications. So there are 4 major complications will be occur. So first, it is the impaired contractility and tissue necrosis, electrical instability, and pericardial inflammation. So first, about the impaired contractility. So here, impaired contractility means, so in the conductive system of the heart, the myocardial SA node will generate the impulses, and it will be passes from the SA node to AV node to bundle of vis, from bundle of vis to Purkinje, and Purkinje fibers takes 2 branches, as we all know this one. So here what happens, so after the MI, the contraction ability will be impaired. Since the myocardial damage is there, the myocardium not able to contribute 100% the contraction, so that will be impaired. So what changes will occur? Let us see. First, it is a ventricular thrombus, stroke or embolism, and then hypotension, decreased coronary perfusion, and increased ischemia. These 3 things will lead to cardiogenic shock. So this is comes under the impaired contractility. So next, it is a tissue necrosis. Here, papillary muscle infarction, ventricular wall rupture. So here this leads to mitral regurgitation, and that leads to congestive heart failure. So congestive heart failure because of the mitral regurgitation and because of the impaired contraction ability also. These 2 things will lead to congestive heart failure. So here, ventricular wall rupture. So here is the cardiac tamponade. Next, it is electrical instability. As I told you before, in the conduction, the electrical impulses are generated from the myocardium, and it is transmitted to the SA node, sinoatrial node, and then it passes to the AV node, and then from the bundle of vis, and then Purkinje fiber. So these electrical impulses pathway will be instability will be there. So because of these reason, the patient may go for arrhythmias. This will be a life-threatening condition, and it will be observed in a very keen manner and should be treated so that we can save the life of a person. Next, it is a pericardial inflammation. So pericarditis, the pericardium will be inflamed, so due to this procedure. So these are all about the myocardial infarction, complications of myocardial infarction. To conclude about the myocardial infarction, so we have discussed in detail about the small introduction about the myocardial infarction, and what are all the universal definition, and what is the global epidemiology behind it, as well as the definition, risk factor, and then what is the etiology and the diagnostic purpose, management, everything. So